Hi, y'all, and welcome back. This is Professor Trulove's Concepts for Nurses series, and I, of course, am Professor Terry Trulove. In this episode, we continue the concept of problems with the brain. And in this episode, we will be discussing seizures and epilepsy. We will be using as our sources Iggy's Medical Surgical Nursing 9th edition and Soul's Introduction to Critical Care Nursing 7th edition. Some of the things that you should review include the different types of seizures, including generalized, partial, unclassified, and even secondary seizures. You should also be able to identify and define epilepsy, whether from primary or idiopathic sources. Seizure is defined as an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons, resulting in alteration in consciousness, motor or sensory ability, or behavior. Now, you should know that this alteration in consciousness could be either that the patient is actively having motor responses, a seizure, or in the case of something like an absent seizure, where the patient simply sort of blanks right out, doesn't really respond. Seizures may be due to a pathologic condition of the brain, such as a tumor. On the other hand, epilepsy is defined as two or more seizures experienced by a person. The International Classification of Epileptic Seizure recognizes three broad categories of seizure disorders: generalized seizures, partial seizures, and unclassified seizures. Partial seizures are also called focal or local seizures, and they begin in part of one cerebral hemisphere. These types of seizures can further be subdivided into two main classes: complex partial seizures and simple partial seizures. Complex partial seizures may cause a loss of consciousness, also known as syncope. It's a blackout that can last 1 to 3 minutes. Generalized seizures involve both cerebral hemispheres and can also be subdivided. Tonic-clonic seizures lasting 2 to 5 minutes begins with a tonic phase that causes stiffening or rigidity of the muscles, particularly of the arms and legs, and immediate loss of consciousness. Clonic or rhythmic jerking of all extremities follows. The patient may bite his or her tongue and become incontinent of urine or feces. Fatigue, acute confusion, and lethargy may last to an hour after the seizure. A tonic seizure is an abrupt increase in muscle tone, loss of consciousness, and autonomic changes lasting from 30 seconds to several minutes. The clonic seizure lasts several minutes and causes muscle contraction and relaxation. You can have only the tonic or clonic movement when witnessing a seizure. The myoclonic seizure causes a brief jerking or stiffening of the extremities that may occur singly or in groups. Lasting for a few seconds, the contractions may be symmetric, that is, involve both sides, or asymmetric, that is, involve one side. In an atonic or akinetic seizure, the patient has a sudden loss of muscle tone, lasting for seconds, followed by something called the post-ictal, that is, after the seizure, confusion. In most cases, these seizures can cause a patient to fall, which may result in injury. This type of seizure tends to be more resistant to drug therapy. When these seizures occur in close proximity to each other, last longer than 30 minutes, or there are two or more without full recovery, we consider this status epilepticus. Primary or idiopathic epilepsy is not associated with any identifiable cause. Secondary seizures result from an underlying brain lesion, most commonly a tumor, trauma, or metabolic or other disorders. Most seizures can be completely or almost completely controlled through the administration of anti-epileptic drugs, or AEDs. These are referred to as anticonvulsants. Seizures in epilepsy may be caused by things such as metabolic disorders, acute alcohol withdrawal, electrolyte disturbances, heart disease, a high fever, stroke, or substance abuse. As you plan the care for the patient with seizure disorder, You should remember that any medications started should not be stopped, even if the seizures themselves have stopped or the recurrence of seizures have gone down, because the seizures or the status epilepticus will reoccur. The actions that are taken during a seizure should be appropriate for the type of seizure being recognized, such as observation, timing, turning the patient on the side to prevent aspiration and to allow secretions to drain, and removing any objects that might injure the patient. Your priority should be to maintain patient safety, and interventions such as side-lying position would be a good idea in a generalized, but may not be necessary when there's not as much motor involvement. Absolutely no restraints. You're liable to break a limb if you try to attach restraints to a patient who is in a full seizure. Never try to force anything into a seizing patient's mouth. Padded tongue blades should never be inserted into the patient's mouth because the jaw may clench down as soon as the seizure begins. Remember that status epilepticus is a medical emergency characterized by prolonged seizures lasting more than 5 minutes or repeated seizures over the course of 30 minutes. Lorazepam and diazepam are the major drugs used for this emergency. As soon as it is safe, you should establish an airway, obtain arterial blood gases, give IV pushes of either lorazepam or diazepam. You can consider rectal diazepam and start considering a loading dose of IV phenytoin, one of the frontline AEDs. A list of medication to review as anti-seizure medications or AEDs include lorazepam, diazepam, diastat, phenytoin, or fosphenytoin. Things to consider when administering anti-epileptic drugs is that you need to evaluate the most current blood level of the medication if that's appropriate and indicated for that medication. Be very aware of drug-to-drug or drug-to-food interactions, of which there are many. You should maintain therapeutic blood levels for maximal effectiveness of that medication. Remember not to administer warfarin with phenytoin and to document and report side or adverse effects, as these are frequent and can cause noncompliance if not addressed. For the patient having seizures, remember again that if they're having a tonic-clonic or complete partial seizure, you need to protect them from injury and to recognize that generalized seizures, such as the tonic-clonic seizure, involve both cerebral hemispheres. Partial seizures, on the other hand, are usually only involve one hemisphere. Continuing with safety interventions, for patients who've had one or more seizures, you should have them placed on seizure precautions. These precautions include having oxygen and suctioning emergency equipment available, being able to have IV access by starting an IV, and keeping the side rails up at all times. You should indicate the reasons for the side rails to meet the Joint Commission requirements. During a seizure, document the patient's body movement and other assessments. The effectiveness of your seizure interventions will partially be determined by the source of your seizures and epileptics. So, your sources may include withdrawal from AED medications, alcohol, other drugs, head trauma, chronic neurological conditions, infections, cerebral edema, and metabolic disturbances. Patients who cannot be managed effectively with medication may be candidates for surgery, including vagal nerve stimulation and conventional surgical procedures, including anterior temporal lobe resection and a partial corpus callosotomy. Education always provides safety, so teach your patients the importance of taking their anti-seizure medications as prescribed. Instruct patients that they can build up a sensitivity to the medications as they age. And if that sensitivity occurs, tell them they will need to have blood levels of the drug checked frequently to adjust the dosage. In some cases, the anti-seizure effect of the medication may decline and this may lead to an increase in seizures. Because of this potential for drug decline and sensitivity, patients need to keep their scheduled laboratory appointments. You may increase patient safety and by increasing medication administration compliance by teaching the family also. Remind the patient and family about the social service resources that are available to assist with not only the disease and its ramifications, but also with things like medication costs. Remind your patient and family that discrimination based on a diagnosis of seizures or epilepsy is prohibited by law, but that alternative employment may be needed. For instance, a heavy machinery driver may have to be reassigned, and that any vocational rehabilitation that is needed for that reassignment may be subsidized by the state or the company. That brings us to the conclusion of this episode of the Neurologic series. I hope you learned a little bit, and we'll see you on the next episode. Bye now.